From the back, she read it. That's exactly right. I'm not your turn around.
How are you doing today? Alright, so today we're going to first start with the homeostatic imbalances that would be related to the heart. You remember we did stop and just first with the cardiac chapter, the heart. So the first set of homeostatic imbalances that we are discussing today, this would be the homeostatic imbalances due to blockage in the circulation. And if you can remind me, please, what are the two vessels that would be supplying the heart with blood, oxygenated blood? Right, right, left. Coronary arteries, coronary arteries. So if I have blockage for any reason to those vessels or one of those vessels or one of their branches, what's going to happen? If I have a transient ischemia, I have a blockage of the circulation for a full period of time, what's going to this result in? It could result in angina. And angina is different from a myocardial infarction. Angina is just pain of the chest, which is going to be relieved later on if you did release the blockage. I don't have a permanent damage to the cardiac muscle cells. I'm just weakening the muscle cells. Compared to a myocardial infarction, I did fully block the circulation going to the cardiac muscle cells. And as I fully block the circulation going to the cardiac muscle cells will not be able to tolerate ischemia for long periods of time. So this will be my myocardial infarction or my heart attack. At this point, the damage is going to be irreversible. So I cannot just replace. If I did open those blocked vessels, would I be able to get those cardiac muscle cells back to work? You know, those are already dead. What's going to happen is I will just be replacing them with scar tissue. So I will just be taking out those dead cells and will be replacing them with fibrous connective tissue. And that's why, as you can see, I will end up having a heart failure. Why? Because I have lost cells that have the ability to contract to pump the blood. All right? So again, what's the major difference between the pectoralis major and the myocardial infarction? Pectoralis major, I am weakening the muscles. Compared to the myocardial infarction, I have muscle cell death. Which one is going to be reversible? Which one is irreversible? Pectoralis, angina pectoris, this would be reversible. Compared to the myocardial infarction, it's going to be irreversible. It's an irreversible thing. Another set of homeostatic imbalances that will be related to the heart is going to be the abnormal intrinsic conduction system. Remember together, what's the normal conduction system? We start by forming the electrical impulses in the SA node. The electrical impulse will travel freely between the cardiac muscle cells of both atria at the same time. And this electrical impulse travels down through the AV node to the AV bundle or the bundle of His. And then the bundle of His or the AV bundle gonna divide into two branches. Those are my right and left bundle branches to conduct the electrical impulses into smaller fibers to the cardiac muscle cells of my ventricles. Those are my Purkinje fibers. This is my normal electrical conduction within the heart. If this conduction is not taking place in a regular rhythm, I have lost the regular rhythm of cardiac muscle contraction due to irregularity of the electrical conduction. I've lost the rhythm. This will be arrhythmia. No or without rhythm. So if I've lost the rhythm, I have problems maintaining my regular rhythm of the heartbeat. This would be my arrhythmia. If I have uncoordination between the atria and the ventricles, like what disease might cause uncoordination between the atrial contraction and the ventricular contraction? If, for example, I've got a heart block. If I've got a heart block, and my atria are following my SA nodes, but my ventricles are not getting all the electrical impulses from my atria, so they have either to rely on the Purkinje fibers. If I have a third-degree heart block, no electrical impulses are passing down, or if some electrical impulses are passing down from the atria, I will follow them. All right, so this here will be recorded on the EKG, P wave, and missed QRST, and then another P wave, followed by a QRST. So you see here, not every atrial depolarization is followed by a ventricular depolarization. This is an uncoordinated atrioventricular contraction. Again, one of the reasons that might result in uncoordination between the atria and the ventricles is going to be heart block. Another problem that might be related, that would be related to the intrinsic conduction, is the fibrillation. And the fibrillation here, I have a rapid irregular contraction, and this will be useless to pump blood, as if I'm not contracting. If I have ventricular fibrillation, I need cardiac conversion. I need to have a reset for my heart. Can I survive with atrial fibrillation? What do you think? Yes or no?
Yes.
Yes. Why? How come? If you are not contracting your atria, how would the blood be moving from your atria down to your ventricles if you're not contracting your atria? Yeah. Only 20% will move from the atria to the ventricles due to atrial contraction, compared to 80% will be moving from the atria to the ventricles due to ventricular relaxation. Suction force created by the ventricular relaxation. Here, it's what drags what pulls the blood down to move down. All right? So if we see on here, yes, I can survive with atrial fibrillation. This is how it's going to look like on an EKG. You see on here, atrial fibrillation, I have very rapid depolarizations of my atria. So as if I have many P waves, many brief and rapid P waves. Not each one of them is going to be followed by QRS. Is this something good or bad? Okay. So do you think if each one is followed by an QRST was after each P wave, will this be something better?
No. Not necessarily.
Now, how did I protect my ventricles from following all those atrial depolarizations? What do you think? What do you think is protecting your ventricles? Why not with every atrial fibrillation I will get a ventricular fibrillation? If I'm getting the electrical impulses to my ventricles from my atria. If I told you I have atrial fibrillation, very rapid contraction due to very rapid depolarization rate of my SA node. So why do you think I won't get the same thing in here in my ventricles? Why not every single P waves that I've got in here will be followed by a QRST? Delay in the AV node, exactly. The AV node here will regulate the electrical impulses passing down, and this is why I need to have this delay. One of the things why it's helpful to have this time delay, for me to allow the ventricles to relax and then contract another time and then relax and then contract another time. Because if I've got an atrial fibrillation, it doesn't have to be followed by ventricular fibrillation. Because the electrical impulses passing down from my atria to the ventricles need to be delayed in my AV node. All right? Moving on to another set of homeostatic imbalances due to defective nodes. So if I have a defect in my SA node, normally I will follow my second fastest node. So normally, what is your second fastest node? This would be your AV node. You remember what did we call the heart that follows, or the rhythm that will be created following the AV node, not the SA node. If I am following the AV node, not the SA node, what did we call this rhythm? Junctional rhythm. Exactly. Remember how it will look like under when we look at on the AKG. If I'm following my AV node, not the SA node, would I have normal P waves? No, I will be missing P waves. No P waves will be recorded. What's going to be recorded? My QRST and then T wave. Would I have the same rate of depolarization like a normal sinus rhythm? No. Which one is going to be faster? Your junctional rhythm or normal sinus rhythm? Normal sinus rhythm is going to be much faster compared to the junctional rhythm. Again, because the rate of depolarization in the SA node is much higher than the AV node. What else might be a problem here? I might have part of the heart that did get crazy and starts to depolarize at a faster rate than the SA node. Which one will my heart follow? The SA node or the new ectopic focus? The part of the heart that starts to depolarize at a much faster rate compared to the SA node. Which one will your heart follow? The fastest node. Your heart will follow the fastest node. So in this case, it's going to be this ectopic focus. This is an abnormal pacemaker that your heart might create. Alright, so if, for example, the most common site here for ectopic, for the development of an ectopic focus is going to be your left atrium. So if I have a node in here that did develop, that depolarizes at a rate faster than the SA node, my heart will follow the new ectopic focus, not my SA node. If I have a defect in the AV nodes, this is what we call the heart block. And remember, what's going to be my problem? Not every P wave going to be followed by QRST. So I will have uncoordination between my atria and my ventricles. Not every atrial depolarization going to be followed by ventricular depolarization. And according to the type of heart block, I will be developing either regular pattern that I'm following or not. So for example, last time when we've seen the AKG, we've seen a second degree heart block, 2 to 1. For every 2 atrial depolarizations, you're going to have 1 ventricular depolarization. For each 2 atrial depolarizations, you're going to have 1 ventricular depolarization, and so on. So this is a regular heart block, second degree, 2 to 1. For each 2 atrial depolarizations, you're going to have 1 ventricular depolarization. This is regular pattern. Some cases, I won't have any regularity. If it's a complete heart block, atria are following SA node, and my ventricles are following Purkinje fibers. All right? Moving on to another set of homeostatic imbalances that will be related to the heart. This would be the abnormal heart rate. If my heart is beating too fast, above 100 beats per minute, this is what we call tachycardia. Tachy means fast. Fast heart. Tachycardia. If my heart rate is below 60 beats per minute, this would be bradycardia. Brady means slow. Slow heart, bradycardia, below 60. Above 100, this is tachycardia. Congestive heart failure. So what is heart failure? What do you think is the definition of heart failure? Not able to pump blood. Not able to pump blood, exactly. So heart failure, simply speaking, this is the failure of the heart to do its job. And what is the job? Is to pump blood. So if I fail to pump enough, sufficient amounts of blood to the organs, this is considered a heart failure. So what might result in heart failure? What will reduce my ability to pump blood? First, might be due to weakening of my cardiac muscles. I have coronary atherosclerosis, and atherosclerosis is the deposition of fats in the wall of your vessels. So if the coronary vessels are narrowed due to deposition of fats in their walls, what's going to happen? The amount of blood delivered to the cardiac muscle cells is going to be reduced. And if I reduce the amount of blood, if I'm not eating, would I be able to work? No. So once you reduce the amount of blood delivered to the cardiac muscle cells, the ability of those cardiac muscle cells to contract and pump the blood will be reduced. Another thing would be persistent high blood pressure. If I have unregulated hypertension, uncontrolled hypertension, can you remind me, what's going to be my problem? What's going to happen to the cardiac output if I have hypertension? Why will it decrease? So if I have hypertension, high blood pressure within my arteries, like this, what's going to be my problem?
Pressure on the outside is greater or
The pressure outside is higher than normal. That's what I'm supposed to have. Yes. So what's wrong with it? I still can't pump the blood. Why it's a problem? Why it might cause a failure?
Because the natural goes much higher to lower.
Higher pressure, so you need to increase contractility. Why?
To reduce pressure.
What is the pressure? What did we call the pressure that you need to overcome to pump the blood out? What did we call this pressure? Afterload. So your problem is in the afterload. And remember, when you increase afterload, what's going to happen to your stroke volume? Stroke volume will be decreased. And what's going to happen to the amount of blood that you are able to pump per minute if the amount of blood that you're pumping per beat is reduced? It is supposed to go down. But remember, in case of hypertension, in order to maintain the cardiac output the same, what your heart needs to do, remember cardiac output equals to stroke volume times heart rate. If my stroke volume goes down and I want to maintain the cardiac output the same, what I need to do for the heart rate? Increase the heart rate. And this puts more stress on the heart. So I'm increasing the number of contractions per minute to overcome this reduction in stroke volume. So faster heart rate, this is one thing. The other thing, I will need to exert more force. I need to increase the contractility. I need to squeeze my cells to pump this blood out against this high blood pressure. So I need to increase contractility. I need to increase heart rate. So what's going to happen to my muscle cells? They will get exhausted. If you're working and your boss is putting lots of pressure on you, what you're going to end up with? Psychological problem maybe? Or you're going to leave this job, right? So, same concept for the heart. If I'm putting lots of pressure on my heart, what's going to happen? My heart will give up. Heart failure. Heart failure. Another risk factor, another cause for heart failure is going to be multiple myocardial infarctions. So here, this is my ventricle. I've got a myocardial infarction. So what happens to the force of contraction? Can you first renew those cardiac muscle cells? Can I divide cardiac muscle cells? No. Cardiac muscle cells are permanent cells. They cannot divide. They are not able to perform a mitotic division for the cardiac muscle cells or the brain cells, for example. Those are permanent cells. So you're going to have the same number of cardiac muscle cells, same number of nerve cells for the rest of your life. So if part of my heart is dead, a myocardial infarction, what I can do is to replace those dead cells with fibrous tissue. So what happens here to the force of contraction? If you have a cart that you're pulling by 10 horses, so this is my cart, and I am pulling this cart by 10 horses. Now you have the same cart, but one of the horses is dead. So now you have 9 horses instead of 10. Would you have the same performance done or less performance? Less performance. And this is a type of positive feedback. So whenever I have a myocardial infarction, what's going to happen? The rest of the heart is going to be working harder. And as the rest of the heart is going to be working harder, put more stress on the living muscle cells. And as I put more stress, more cells will be dead. And as as I get another myocardial infarction, rather than having 9 horses, now I would have 6 horses. So in order to pull the same cart for the same distance, what's going to happen? I need to put more stress on those remaining horses. So I put more stress on the remaining cardiac muscle cells. This will cause another myocardial infarction and another myocardial infarction to the extent where I'm not able to pump the blood to be delivered to my organs. And this is what we're going to call heart failure. So having multiple myocardial infarctions will reduce the force of contraction and will reduce the ability of the heart to pump the blood to reach my organs. Another cause for congestive heart failure would be dilated cardiomyopathy. And the dilated cardiomyopathy might be resulting from many things. One of them is just a viral infection. So a viral infection can cause a myocardial, a dilated cardiomyopathy. All right? All will result again in failure of the heart to pump the blood to maintain adequate cardiac output. Moving on to congenital heart defects. The first congenital heart defect here is going to be the ventricular septal defect. Can you remind me of the normal circulation in the heart? So you're getting deoxygenated blood to which chamber of the heart? Right atrium. Through those veins, those big veins, those are mine. Superior vena cava and then right atrium gonna allow the blood to travel down to the right ventricle, and then we'll be pumping this blood up to the pulmonary trunk to reach my lungs, and then the oxygenated blood returning from my lungs would be drained through the pulmonary veins into my left atrium. The blood now is going to travel from the left atrium to the left ventricle, then it will be pumped up to be distributed through your aorta. Right? So if I have a defect in the septum that separates my right and left ventricles, like this. Is there any problem?
You can't pump the blood out.
The blood will be mixed.
Yeah.
First, which side has a higher pressure? Your left side or your right side? Left side has a much higher pressure. Remember, the left ventricle has a much thicker wall. And why do I need to have a thicker wall on the left side? Because I am pumping the blood against a much higher resistance. So blood is traveling all the way to my brain, to my toes, to my arms. By this force exerted from my left ventricle. Compared to the right ventricle, is only be pumping the blood to my lungs, which are very close to the heart. So I don't have much resistance to overcome from the right side normally. So the blood is going to always be moving from left to right or right to left. If I have a defect between the right ventricle and the left ventricle, will the oxygenated blood travel like this, or the deoxygenated blood will be traveling from the right to the left, like this? Left to right, right to left. So again, which side has a higher pressure? Your left. Everything is trying to move from high to low. So again, will I be traveling from left to right or right to left? Now we're good. Alright? So again, the blood is traveling from higher pressure to lower pressure. Higher pressure to lower pressure, which means from left to right, because the left ventricle has a much higher pressure compared to the right ventricle. Is there any problem I have? Is it a problem?
You're not going to be getting as much blood to the organ.
I'm not getting as much blood as I need to my organs. What do you think? Is this gonna be my problem in here?
Or oxygen.
So can you remind me what is cardiac output? Can you remind me of cardiac output? What's cardiac output? This is the amount of blood pumped in 1 minute from each ventricle, right? Resting cardiac output. What was the resting cardiac output?
Heart rate.
Resting cardiac output. What is the amount of blood that you're gonna be pumping?
Oh,
5 liters per minute. And remember, a maximal cardiac output. Maximal cardiac output is about 4-5 times this amount, right? So it can go up to 25 liters per minute. So if each time I will be pumping blood, some of this blood gonna be traveling from my left side to the right side. Is this a major problem to me?
Yes.
If the resting cardiac output is 5 liters and you can pump 25 liters per minute, if some of this blood is traveling from the left side to the right side, will I have enough blood to reach my organs?
Yeah, more blood is in your ventricle.
Again,
Going from 2 different spots.
if my resting cardiac output is 5 liters and you can pump up to 25 liters normally, if I'm telling you that rather than having those 5 liters passing to your organs, you're going to be allowing ½ liter to pass from the left to the right and 4.5 to pass to your organs. Can you substitute and compensate for this small reduction in the volume of? Yes. So will there be any major manifestation on this child because it's a congenital problem? No. I won't have a major problem. I won't have a major problem. Can I perform my normal, regular activities? Yes. My problem is if this was not treated early enough. What's going to happen? Over time, right ventricle is supposed to pump 5 liters per minute. But every time it contracts, you are adding more blood above those 5 liters. So what's going to happen over time, over years? Rather than pumping 5 liters for those short distance, you're going to be adding ½ liter, ½ liter, ½ liter. So what's going to happen over time? As if you are training your biceps. What's going to happen to your biceps when you train and when you keep training your biceps, what's going to happen? It's going to get bigger and stronger. So this is what happens over time. My right ventricle will be thicker than the left ventricle. And if it becomes thicker, what's going to happen? It will create a pressure higher than the left. And now the blood will be moving in the opposite direction, and this is when I will have a problem. Because at this time, and only at this point, when the right ventricle has a higher pressure than the left ventricle, the deoxygenated blood now is going to be traveling from the right to the left. Now you are conducting deoxygenated blood to your organs. And this is when I would have the problem. But early in life, is it a major problem to me, having a ventricular septal defect? No, it's not. Because you can't compensate this reduction, you can't compensate this amount of blood that travels from the left to the right. by increasing the force of contraction, by increasing the heart rate. But over time, as you are overloading the right ventricle, what's going to happen? Right ventricle will be stronger, and now it creates pressure higher than the left ventricle, moving the deoxygenated blood from the right to the left. And this is what we what we call the Eisenmenger syndrome. Eisenmenger syndrome is when the right ventricle becomes stronger than the left ventricle. All right, and now I will have a problem because I'm conducting deoxygenated blood to my organs. This will cause the bluish discoloration of the skin. I will have cyanosis. I will have clubbing of the fingers. My fingers will be like drumsticks. Let me show you the clubbing of the fingers on here. See on here, I have major clubbing in this patient, so I will have bigger nails, and this is one of the signs of delivering deoxygenated blood to your organs. Clubbing of the fingers will be manifested. Also cyanosis, which is a bluish discoloration of the skin. So I have cyanosis. Bluish discoloration of the skin. All right. So I will start without a problem, without a major problem, but if not treated, it will cause problems later on in life. This is my ventricular septal defect. So in most of the cases, if it was too small, I will not be performing the surgery, and I will leave it. It might close by itself. If it was large defect, if I did have a large defect, at this point only I will have to interfere and perform a surgery, because most probably it will not close on its own.
How can you detect it? How would you be able to know that this baby has that?
So it will be detected by ultrasound. By the ultrasound. This is one thing, and the other thing, when we perform auscultation of the chest of the baby, if it was a small defect, it will be producing a harsh sound. All right, this will cause a murmur, a type of murmur.
What stage is it coming correct?
At what age?
At what stage? So you're saying that the right ventricle is enlarged, right?
Yeah, it takes years, 6, 7 years.
So how do you correct them?
It's a
Say you close the vein between it, but what about the muscle?
Yeah, you're gonna be attaching both sides together to close the defect. You are asking about the procedure of the surgery. I don't know the details for the procedure itself, but generally speaking, they will be closing this defect.
I'm just saying, is it a point that it's just incorrectable? You have to get a new heart?
New heart, it won't be that bad. It won't be that bad to cause a failure.
So if you correct the septum, what about your right ventricle is still
It's big,
larger than
having a high pressure.
yeah.
So it should be corrected before all this happens.
Okay.
If not, this patient is at a risk of developing heart failure early in age. So at earlier age. So I don't have to wait until late 50s or 60s to develop heart failure. I will develop it early in life. All right. but how exactly we're going to be performing the surgery, I'm not exactly sure of the procedure. All right?
Is this something that happens, like, it's gonna be born with, or it just happens?
Yeah, it's congenital, means you're born with it. The person will be born with it. All right, so if it's large enough, it can be detected before delivery by ultrasound, and if it was small, it's going to be detected by auscultation, by hearing the chest of the baby. All right, moving on to another congenital defect. This would be the coarctation of the aorta. So my aorta here is going to be narrowed. I don't have a septal defect, but I have narrowed aorta. So rather than having this patent aorta here, I would have narrowing of my aorta. So what's going to be my problem? What do you think?
Not to be able to deliver enough organs.
So I'm still able to pump the blood.
It's just
But it's going to be harder. So what happens is the pressure that I want to overcome, high pressures that you want to overcome. Exactly. It's as if a baby is born having hypertension. So rather than having hypertension at 50 years of age, he developed it from day one. He has a very high pressure that he needs to overcome to push the blood against this narrowed aorta. This is called like the coarctation of the aorta. It will have the same outcome like having hypertension, but it's going to be very early in age. All right, so I will have to overcome this defect. So I will have hypertrophy of the ventricles. My ventricles going to be larger and bigger. I will have fast heart rate. This is compared to the other congenital anomalies, this would be much easier to fix. So you're going to be putting a stent, you're going to be inflating a balloon inside the narrowed aorta, and you put a stent to keep it open. All right? This is for the coarctation of the aorta. Moving on to another homeostatic imbalance that would be related to the congenital heart defect. This could be the tetralogy of Fallot. Tetra is 4. So here I have 4 defects, not only one. So first I have a ventricular septal defect. So I have a defect between the right side and the left side. The other thing, I have narrowed pulmonary trunk. And in the same time, I have overriding aorta. So the aorta is receiving blood from the right and the left sides, like this. So you see here, what's going to be my problem? My problem is when the right ventricle tries to pump the blood, which side is going to be easier to go to? The narrowed pulmonary trunk or the overriding aorta? Overriding aorta is going to be much easier. So this baby will have cyanosis from day one, unlike the VSD, unlike the ventricular septal defect. Why? Because from day one, I am having right to left shunt. From day one, the deoxygenated blood is going to be traveling from the right side of the heart to the left side of the heart. And as I get deoxygenated blood to the left side, it will be pumped up to my organ through the aorta. This is again called the tetralogy of Fallot. Tetralogy of Fallot. And the details are not under the scope of this course. Details of those defects, how to treat them, manifestations, all this will not be under the scope of this course. All right? So generally speaking, ventricular septal defect, I won't have a problem early in age because simply the oxygenated blood will be traveling from the left side to the right side until when? Until the right side creates a higher pressure. And as I create a higher pressure, the oxygenated blood is going to be traveling from the right to the left, and at this point I would have a major manifestation, major problem. Here, coarctation of the aorta, I have a lot of afterload I need to overcome, as if I am born with hypertension. Here I have multiple problems in the same time. So I have narrowed base of the pulmonary trunk. I have overriding aorta. Aorta is going to be getting the blood from the right and left sides. I have a VSD, ventricular septal defect. Those patients with tetralogy of Fallot will have cyanosis from day one. I have bluish discoloration of the skin from day one. Questions? Moving on to our last set of homeostatic imbalances, I will be describing major clinical topics that are not required from you, but just to give you a sense of what we'll do. All right, so I have two kinds of defects that might take place in the valves. Again, how many valves do I have in the heart? 4 valves. I have AV valves, which are located between my atria and the ventricles, and I have my semilunar valves, which are located at the base of my arteries, at the base of the pulmonary trunk, at the base of my aorta. I have two kinds of defects that might take place in my valves. I have either stenosis, and stenosis here I have narrowed valves, and I have regurgitation, and those are leaking valves. So again, what are the two kinds of defects that might take place in my valves? Either stenosis or regurgitation. So normally, do you have sounds of your blood? Is your blood producing a sound? Yes or no? No. What is a heart sound? What are the heart sounds that you hear? Are closure of the valves. Normally, do I hear the blood flow? No. Can I hear the blood flow in my heart? No. Can I hear the blood flow in my arteries? No. So normally, you don't hear the blood flow. Why? Because the blood flows in a lamellar pattern, like this. Doesn't produce a sound. In my arteries, if I did apply a pressure on the artery, again I'm talking about arteries now, please pay attention, don't try to write down anything now, just make sense of what we're saying. Alright, so here the blood flows in a lamellar pattern, it doesn't produce a sound. What if I did compress the vessel? I did apply a pressure from outside higher than the pressure inside. What's going to happen? So my vessel will kink like this. And now, when I kink my vessel, because I did apply pressure higher than the pressure from inside, this will disturb the blood flow. And we're going to call the blood flow now is turbulence. So I have a turbulent flow. So again, Normally, the blood flow doesn't produce a sound. If I did put a pressure on my artery higher than the pressure inside, this will narrow the vessel, and as a result, I will develop a turbulence in the blood flow. This turbulence will create a sound that I can hear. The sound that we create in the vessel, this is called a bruit. Bruit in French is noise. Alright, so again, normally I don't have a sound for the blood flow, but whenever I compress this vessel from outside at a pressure higher than the pressure inside the vessel, it's going to create a sound that we call a bruit. And this is what we're going to hear when we take the blood pressure. We can hear the blood flow through the brachial artery, and what we hear is the bruit. Same concept in my heart. If this is my atrium, this is my ventricle, like this. Blood flows down from the atrium to the ventricle in a lamellar pattern. Blood will be pumped out from the ventricles to the artery in a lamellar pattern. So will it produce a sound? No. It doesn't produce a sound. When will I have a turbulence in the blood flow to create a sound for the blood flow? Whenever I have narrowed vessels, narrowed valves. Whenever I have narrowed valve, what's going to happen? The blood flow will be turbulent. And this turbulence of the blood flow will be producing a sound. Or, if the valve is leaking, so I am moving the blood backwards. So the blood that moves backward, it's not going to be moving in a lamellar pattern. So it's going to be turbulent, so it will be producing a sound. So again, normally I don't produce sound from my blood flow. If I have turbulence in the blood flow, at this point I will hear a sound for the blood flow. The sounds that I will hear on my arteries, this is what we call a bruit. And this happens when you compress the vessel from outside at a pressure higher than the pressure inside the vessel. Here in my heart, again, the blood doesn't produce a sound unless it becomes turbulent. Whenever I have turbulence of the blood flow, moving from one chamber to the other, moving from the atria to the ventricle, or from the ventricle to the vessel, at this point, once I create a turbulence in the blood flow, this will create a sound, and this sound is what we're going to call a murmur. And murmure in French is to whisper. So again, a sound on the artery, this is a bruit. Sound in the heart, this would be sound of the blood flow in the heart, this would be a murmur. So let's see here, how would I be able to tell what defect and which valve is going to be defective? According to what? According to what I hear. So you see on here, first example, let's say I will start with the left side. I will only draw the left side of the heart. So this is my left atrium, this is my left ventricle, and the vessel that moves out, this is my aorta, like this. And I'm telling you that I have a defect in my mitral valve. I have mitral stenosis. What I mean by stenosis, that the valve is narrowed. So as the blood travels down from the atria to the ventricle, like this, will it be able to travel in a lamellar pattern? No, it will become turbulent. And this turbulence here of the blood will create a sound that we call a murmur. So when would you hear the murmur? So if I have love, dup, love, dup, love, dup, love, dup. When would I hear the murmur? After first, after second? What do you think? If I have mitral stenosis, the turbulence of the blood is taking place when in the cardiac cycle? When my ventricles are relaxing or my ventricles are contracting? When my ventricles are relaxing. Why? Because when you relax your ventricles, the blood flows down from your atria to your ventricle. And this is where I will have a turbulence in the flow. And which heart sound marks the beginning of the ventricular relaxation? First or second? Mine? Go back to your cardiac cycle. Which one will take place? First heart sound, second heart sound. That marks the beginning of ventricular relaxation. When you relax your ventricles, which valves do you want to close? AV valves or semilunar valves? Semilunar valves. So semilunar valve closure will result in second or first? Second heart sound. So when I relax my ventricles, the blood will flow from my atria to the ventricles, and this blood will pass through a stenotic valve, and as it passes through a stenotic valve, this will result in, again, turbulence of the flow, producing a murmur. And this murmur is going to be diastolic or systolic again? Diastolic. So what I will hear is lub, dub, sh, lub, dub, sh, lub, dub, sh, lub, dub, sh. So the murmur is after my second heart sound. So this would be a diastolic murmur. Diastolic murmur. What if I have a regurgitating valve? So let's stick to the mitral valve. Still, I am looking here at my left side of the heart. But this time, the mitral valve is leaking. I have mitral regurg. This is mitral stenosis, and this is mitral regurg. When would I have a turbulence in the blood flow? If it's leaking, will I have any problem moving the blood from the atria to the ventricle? Do I have any problem passing through a leaking valve? No, so I won't have a problem passing here from the atria to the ventricle. So this will not be producing a sound. When would you produce a sound if it's leaking? If you are moving in an opposite direction. If you're moving up from your ventricle to your atria. And when will this take place? What do you think? During ventricular contraction or during ventricular relaxation? Contraction, because the blood is trying to move from high pressure to low pressure. So a mitral regurg will result in a systolic. So what I will hear is lub, sh, dub, lub, sh, dub, lub, sh, dub, lub, sh, dub, lub, sh, dub. First, heart sound, closure of the valve, closure of AV valves. So it will close, producing a sound. But because it's leaking, what's going to happen? It will allow the blood to keep flowing. So it will produce a sound during ventricular contraction. Because during ventricular contraction is when you have a high pressure in your ventricles. Alright? And then what's going to happen? You relax. And when you relax, what's going to happen? You close semilunar valves, resulting in second heart sound. So you're going to have a murmur between first and second, after the first. Compared to a mitral stenosis, when would I have the murmur? When I relax. When I relax, this means after my second heart sound. So you got love, dub, sh. The same will be applied to all the four valves. You need to figure out where is the blood going. And accordingly, you will be able to tell which one would be systolic, which. If I have a ventricular septal defect, if I have a defect in my septum, like this, VSD, that we've just seen, what do you think is going to be the murmur? When the murmur will be taking place? When you contract or when you relax? When you contract, allowing the blood to move from the left to right. But because this is an abnormal path for the blood will be turbulent. And if the blood is turbulent, what's going to happen? It produces a sound. It produces a murmur. Alright? Can you please turn on the lights? Alright, so are we expected to diagnose patients by giving you the murmurs? No, you're not. You're not supposed to diagnose at this level. Alright, but I'm just showing you how we can use this information to diagnose patients. So what do we need to know? We need to know that we have two types of defects for the valves. Those defects are either stenotic or regurgitant. So I might have a stenotic valve, narrowed valve, or a regurgitating valve, leaking valve. Alright? We need to remember, of course, what is first heart sound. This is taking place during ventricular contraction, and it's marking AV closure. And second heart sound, this is resulting from the semilunar valve closure. And this is marking the beginning of ventricular relaxation. Questions? Questions? Question? Are you sleeping? No? All right. This completes our discussion on the heart. So moving back to the blood vessels. We can have a break for 10. We come back to discuss more about the blood vessels, and we will have the dissection. So please bring your coats in. On here, this is how the circle of Willis looks like. Here I'm looking at the base of the brain. So this side, getting closer, and then I'm looking at the base. You will see two vessels coming up, which are the branches from my subclavian vein, subclavian arteries. Subclavian arteries will give rise to the vertebral arteries, And then the vertebral arteries here will form my basilar artery. Basilar artery will travel up and will be forming an anastomosis, a connection with my internal carotids. So those are my internal carotids, right and left internal carotids. This will be my basilar artery. And this connection here is going to be my circle of Willis. You're going to be getting blood out to the different parts of the brain. So two vessels will come out from the circle of Willis that will travel up here. Those are my anterior cerebral arteries. And here, those will be my posterior cerebral arteries. On the side, this will be my middle cerebral arteries. Alright? The connection here is what we call the circle of Willis. Again, those are my vertebral arteries forming together my basilar artery. Some people get confused between basilar artery and basilic vein. Don't get confused. This is basilar and this is basilic. Alright, the basilar artery will share with the right and left internal carotids to form this connection here at the base of the brain. This is the circle of Willis. Then I will start to distribute the blood to different parts through anterior cerebral arteries, middle cerebral arteries, and posterior cerebral arteries. All right? So looking here at the venous drainage of the brain. So this one would be my superior sagittal sinus. This one is my inferior sagittal sinus, and the connection here is going to be my straight sinus. This is again my straight sinus that connects the inferior to superior sagittal sinus. See on here, this will go down, and this will be the transverse sinus that will be draining both superior and inferior sagittal sinuses. Then I would have this flexion on here. This flexion is my sigmoid sinus, and the sigmoid sinus will drain into my internal jugular vein that carries the blood down. So if I'm following the internal jugular vein, the internal jugular vein with the external jugular and the subclavian vein all here. So continuation of the subclavian. Let me move here because it's hidden by the clavicle. So this would be my subclavian vein. subclavian, internal jugular, external jugular, and subclavian all will drain into this vessel, which is my brachiocephalic. Brachiocephalic from the right side and the left side will drain into my superior vena cava that drains into my unit. I'm not sure how to move this down. So you see here, right and left brachiocephalic veins drain into my superior vena cava that drains into my right ear. All right? It's much more difficult to deal with on here rather than with a trackpad or something. Because we have less gestures by the mouth. All right? Questions? So on a piece of paper, please. All right. So let's start. So let's do this as a homework. All right, for next time, and we can do the dissection now. All right. So person drinks alcohol. So vodka, for example. This vodka will travel to his brain and did affect his consciousness. All right, so I have disturbed judgment. And then it will be filtered out in the urine. So mention the pathway of the vodka, starting by the absorption. So once you absorb it, travels to the prefrontal cortex of the brain, and then you're gonna filter it in the kidney. So mention the vessels, chambers, valves that you're gonna be passing through, starting by absorbing the alcohol in the small intestine until you get rid of it in the urine, bathing through the brain. To be more accurate, to the anterior part of the brain, prefrontal cortex. That's why it did affect the judgment. All right?
You said it one more time.
So, person did drink alcohol. This alcohol was absorbed. It did affect his judgment, means it did reach the prefrontal cortex, anterior part of the brain. And then after that, he would be able to get rid of it by micturition. So it will reach its kidney, his kidney, and he will be able to filter it out in the urine. So mention the pathway, stating the vessels, blood vessels, that you're going to be passing through, starting from the small intestine until it gets out in the urine, passing through the prefrontal cortex. All right? This will be for next time. Today we are doing the dissection, so please form groups of 6 or 7 and get your specimens, trays, gloves, everything that you need. Here.
how to figure out right and left.
Yeah.
You see on here, apex. This is my apex.
Right.
So it's going to be formed by this chamber.
Right.
What is the chamber that forms the apex? This will be my
ventricle.
left ventricle. And this will be my
Right ventricle.
right ventricle. So you start here, lateral border, cutting the lateral border of the heart here, like this.
Okay.
Starting from the right atrium,
Okay.
right ventricle,
Okay.
and you expose the right side.
Okay.
Right?
Got you. The tendons for the AV valve or the semilunar valve?
And trapezial valve too.
Because that's what
Yeah,
we need help trying to find the difference between the two.
So the semilunar valve are much more difficult to reach, and they would be located at the base of the valve.
I didn't get down up in there. I didn't get up in there enough.
So you're looking on here. See, this will be my right atrium, and those will be the cusps of the tricuspid valve.
Okay.
That will be allowing the blood to travel from the right atrium to the right ventricle.
Okay.
If you're trying to move up from the ventricle, up, you're going to be moving into a vessel. So this is my vessel on here.
Okay.
So let me expose this in here. So you need a much deeper exposure here for you to check the base of the pulmonary trunk. So let me have
Did you
scissors.
just tear the
Can I have-
valve? You tore the valve already?
You see, I have all this is my tricuspid valve.
Okay.
Ah, okay, so we did have it.
So you
So
still
then
have
we tore it up,
you
basically.
still have part of it to check.
Okay.
But here I'm exposing the pulmonary trunk.
Okay. That's the pulmonary trunk. Got you. Oh, I see it.
Okay, that's the start of the left. Which I'll probably just label that one so I can destroy it, so we'll already have it.
So you see here, I'm exposing the base of the pulmonary trunk. This is what
Yes.
we're looking at.
Yes.
So if I'm trying to go upwards into the pulmonary trunk, you don't have a problem. But if you're trying to go backwards, what will hold you?
So that's the semilunar.
That's the similar valve.
Half moon. This is
Okay.
half moon.
Okay. That's
This is
the
too
semilunar.
sharp to point with. When you have a here we go. Yeah, see? I can move up from the right ventricle up to pulmonary trunk. When my ventricles are relaxing, I will try to go backwards. What will
Okay.
hold me? My
This-
pulmonary
Similar
semilunar
valves.
So this
Okay.
will be my pulmonary semilunar valve.
Okay.
Here, if you want to have a better exposure on the other side as well, you can do this. No major problem. So I get better exposure to the right atrium here, and the blood is gonna be flowing down from right atrium to the right ventricle.
Okay.
When it tries to go back up, close tricuspid.
Closed tricuspid
When you
valve.
try to go back up,
Low pressure.
Got you.
tricuspid valve will hold me,
Okay. Cool.
prevent me from going up to my right atrium.
Okay.
So again, this would be my pulmonary trunk, this would be the base, and this would be pulmonary semilunar valve.
Valve.
Here, this would be the right atrium, right ventricle, tricuspid valve, chordae tendineae, and the finger-like projection you see on here.
Yes.
This finger-like projection to which the cords are attached, that are attaching the cusps.
Yes. That's the
See here,
muscles.
the papillary
Papillary
muscle.
muscle.
Or
Papillary
that's the stronger side.
No, this is the weaker side. This is going to be much more prominent when you cut the left side.
Okay.
Everything is going to be larger, bigger, and more.
Try to open it and see if you understand.
Oh, what you doing now? You just recording me? Mm-hmm. Oh.
Yeah, interesting.
Oh, okay. So let's show the take a picture of this real quick to show the thickness difference. Okay, gotcha.
Oh, yeah, see it.
Oh, Lord, I just ripped a tendon.
She needed to do that a little bit.
Yeah, don't cut towards your hand. Turn around.
Oh, yeah.
Wait,
cut away.
what's this? This is kind of. What y'all think this white thing is?
That's your,
Right here.
that's part of the,
Hold on, maybe this is the
Right,
Let me see. Maybe this is the.
right there.
I feel so weird. It's like I really don't want to cut that. We got to though. Gotta cut this. Oh, so
heck yeah, man.
all these is that tendon stuff. Take a picture of this just because. Okay. The what?
Bicuspid. Bicuspid is on the.
What else do we
left
have to look
side.
at? Pull up the list. So where's that valve for the aorta? Where is it? Nope. Oh, it's right here. Okay, cool.
You did the differences. You looking for right
Yeah. Oh, I like that.
ventricle.
Okay. So difference between thickness. So he got that in a couple pictures.
Left and right
Right.
ventricle.
We got that interventricular
Septum.
What's that?
That's what separates the right and left ventricles.
Oh. Okay.
So that's the center of it.
Pretty much think that's it.
Okay. I think we got that in a couple pictures
Yeah.
though. Okay.
And then
Mitral valve. The mitral valve, that's what lets the left atrium blood flow to the right atrium. So let me find the valve real quick.
You getting in there? You seeing everything?
Oh, here goes the valve. Okay.
And then the last one, 12.
Aortic semilunar valve. Oh, that's right. Dang, I just got that. That's like where. Wait,
Mitral
no.
valve is the bicuspid.
Okay, so it's weird because where is the? Let me cut this tendon. I'm sorry. Ooh, ooh.
Or you cut the tendon off.
I know.
Right.
Okay.
You already got a picture of it. So.
Wait. No, don't take a picture of
sorry.
that because that's not the valve. Unless you're taking pictures for you.
No, I'm recording in general, but I'm just.
Lift it up.
Oh, here go the valve. Okay, we gotta cut this to get to the valve. Excuse me. We're looking for
Under
the
this.
aortic semilunar valve. And that valve
Hold on. There you go.
was right here. Can you see me pointing to it? Hold on. Hold on. Let me. Okay. I think we got everything.